Atrial fibrillation is an uncommon arrhythmia for us to see in the childhood population. The most common contexts that we see it are with left-sided AV valve disease, in the context of associated supraventricular tachycardias, and in patients who have lone atrial fibrillation but in a familial fashion. When we see atrial fibrillation present in a young patient, it should typically prompt us to perform electrophysiologic testing, primarily to search for an underlying SVT mechanism rather than proceeding to pulmonary vein isolation procedure. It's been shown in general that ablation of the underlying SVT substrate will generally prevent further recurrences of the atrial fibrillation in our own data as well as others. The setting of Wolff-Parkinson-White syndrome clearly represents the most important context of atrial fibrillation in this younger population. It's well known that sudden death occurs in Wolff-Parkinson-White syndrome, and the mechanism is the rapid conduction of atrial fibrillation to the ventricles, leading to sudden death in WPW patients. Importantly, this event may occur as a sentinel event in at least half of the patients who present with this arrhythmia, and the incidence has been estimated anywhere from 1 to 2 per 1,000 patient years, corresponding to 1 to 2% incidence per decade. And I think this is important when we apply this to the younger population. These are based primarily on adult data, by the way. Risk factors include inducible tachycardia, a short accessory pathway ERP, rapid conduction to the ventricle during atrial fibrillation as demonstrated in the electrophysiology laboratory, and the presence of multiple accessory pathways. 20 to 30% of patients who undergo EPS risk stratification will meet one or more of these criteria, which would generally prompt us to consider catheter ablation. To date, universal EPS evaluation as a risk stratification has not been recommended in asymptomatic patients, although the practice is very commonly undertaken among pediatric electrophysiologists. We therefore tried to study the effect of isoproterenol on accessory pathway conduction in children. We think that isoproterenol certainly enhances accessory pathway conduction and may be important in this younger population in whom many of these events occur during exercise. The question may be asked, is there a risk of sudden death in the young asymptomatic patient with WPW? In the past, our conventional wisdom was that atrial fibrillation is primarily an adult arrhythmia. Therefore, the risk in asymptomatic children is likely less than the 0.1% per year incidence that has been described in many adult natural history studies. However, among the young patients, even a 1% risk per decade may not be an acceptable risk. Certainly, high-intensity activities that these patients engage in may potentiate their risk further, and it has been shown, at least in some studies, recent population data, that much higher risk can be seen in the asymptomatic young patients than has been previously ascribed to the adult population. It's also been shown that anesthesia may attenuate accessory pathway conduction, or at least the inducibility of tachycardia, and thus may underestimate the risk of the patient's WPW when they engage in physical exertion. We performed a retrospective review of patients undergoing EP testing for Wolff-Parkinson-White syndrome in our children's hospital. We found 150 patients that had undergone isoproterenol challenge during the course of their EP testing. Patients' average age was almost 14 years of age, but ranged from less than 1 year of age, and one patient actually in adulthood who's been excluded from most of the data here. 61% were male. We performed a retrospective review of isoproterenol and its effects on accessory pathway conduction in a pediatric population, primarily of WPW patients undergoing electrophysiology testing. We found 150 patients, which represented most of the population we had studied over the course of 4 years, who had been challenged with isoproterenol during their EP studies. Most were in the pediatric and adolescent population. We had one adult patient that we excluded from most of our data analysis. Slightly more than half of these were males. Of those patients, 26 were asymptomatic. 100 had presented with palpitations and or documented reentrant tachycardia, and 22 patients had presented with a history of syncope. All patients underwent standard comprehensive electrophysiology testing, and in our facility, this is done standardly with propofol anesthesia. It's important to note that it has been studied that propofol does not itself attenuate accessory pathway conduction, whereas inhaled anesthetics have been shown to decrease accessory pathway conduction. After the induction of anesthesia and deployment of catheters, we studied accessory pathway conduction and attempted induction of AV renter tachycardia and atrial fibrillation in all of our patients. Accessory pathway conduction was assessed at baseline and with infusion of isoproterenol beginning at 0.02 micrograms per kilogram per minute and a maximum of 1 microgram per minute regardless of patient size. We studied the accessory pathway ERP, one-to-one conduction over the accessory pathway during sustained pacing. We attempted to measure the shortest pre-excited RR interval during atrial fibrillation, and the induction of AV renter tachycardia was noted, as this has been shown to be an additional risk factor for sudden death. We correlated these parameters by age and by the nature of their presenting symptoms, and we also compared the data that we obtained to historical controls that have been previously published. Our findings were that there was no difference in the 3 accessory pathway conduction properties that we studied according to the manner of their presenting symptoms, and this has been found in the past. Namely, symptomatic patients are not necessarily the patients who can display either the induction of tachycardia or the potential to conduct rapidly during atrial fibrillation. And isoproterenol significantly shortened all 3 of these accessory pathway conduction properties to a highly significant degree. The degree of effect of isoproterenol was similar among all groups, whether we subdivided the patients according to age or subdivided the patients according to presenting symptoms. Somewhat keeping with the notion that higher risk may be seen in the younger population, we saw a modest but highly significant age correlation with both the baseline accessory pathway ERP and one-to-one conduction patterns and the conduction patterns, those conduction characteristics during isoproterenol infusion. Interestingly, the shortest RR interval during atrial fibrillation was not significantly affected by isoproterenol, at least not to the same degree as these other parameters. Compared to the historical controls in adults that we examined, who were studied in a fairly similar fashion, albeit with sedation rather than with anesthesia, the accessory pathway properties were clearly shorter both at baseline and after infusion of isoproterenol. This slide shows the effects of accessory pathway characteristics during isoproterenol as compared to baseline. At baseline, the mean accessory pathway ERP was slightly longer than 300 milliseconds. After the infusion of isoproterenol, it shortened significantly to where the mean was well below 300 milliseconds and encroached upon the range that we would start to consider denoting high risk. Similarly, one-to-one accessory pathway conduction and the shortest RR interval in atrial fibrillation was significantly shortened by isoproterenol. I think the latter point is actually interesting, since there has been some trepidation about the use of beta blockers in patients with Wolff-Parkinson-White syndrome. The concern being that if you attenuate AV nodal conduction with a beta blocker, you may actually prevent concealed retrograde penetration of the pathway, and in so doing, you may actually facilitate antegrade conduction over the accessory pathway. This was clearly not what we saw in our population using adrenergic stimulation. This chart depicts the accessory pathway conduction properties both at baseline, the 2 lines at the top, and after infusion of isoproterenol, both for accessory pathway ERP and one-to-one accessory pathway conduction, as divided according to age. I think it's particularly noteworthy that while we could not show an age-related difference to the accessory pathway conduction properties according to age, there was a most pronounced shortening of the accessory pathway ERP in the youngest population. What was most interesting in our review of the data was the absolute changes in the accessory pathway conduction characteristics after exposure to isoproterenol was sometimes quite substantial. Indeed, the most dramatic shortening in conduction properties that we observed in our population was a shortening of 390 milliseconds in the accessory pathway ERP in one patient, and a facilitation of conduction during atrial pacing of 510 milliseconds from baseline as compared to isoproterenol. The shortest pre-excited RR interval that was measured at baseline, in some cases, that interval was decreased by as much as 240 milliseconds in one patient. These findings, I think, had an important impact on clinical decision-making in these patients and carry great implications as we employ this in a larger setting. Tachycardia induction was clearly much more common with isoproterenol, and this was significant among all the symptom groups, both those who had presented with prior tachycardia as well as those patients who were asymptomatic. Tachycardia inducibility was especially enhanced among the asymptomatic population, and this may be important if we apply this screening to our asymptomatic patients in a larger context. The so-called high-risk criteria for accessory pathway properties was seen significantly more often when we infused with isoproterenol. For example, shortest pre-excited RR interval, which is thought to be the most predictive of the accessory pathway properties, was seen in only 7% of our population at baseline, again, in the anesthetized state. But after infusing with isoproterenol, roughly 40% of our patients displayed this property, as shown in this slide. Here we have patients subdivided into those who were asymptomatic prior to their study, those with documented tachycardia, those presenting with palpitations, but no documented tachycardia, and then the syncope patients, which we broke down into patients that were most likely experiencing their syncope due to neurally mediated mechanisms, and those who presented a history much more likely to be arrhythmic in nature. Those patients with palpitations, documented documented SVT, and arrhythmic syncope by history were much more likely to have tachycardia induced after we infused isoproterenol. Even the patients who were asymptomatic, as I noted, almost 40% of those patients had inducible tachycardia. And studies have shown that with time, roughly 30% of patients who present with asymptomatic WPW prior to age 40 will go on to develop symptoms. And I think this bears this out. Again, if we look at those patients who met the various potential criteria denoted as high-risk criteria above and beyond tachycardia induction, it was much more commonly observed after we infused isoproterenol, as shown in the darker bars on this chart. Shortest pre-excited RR of less than 250 milliseconds is what has been mostly used, and roughly 40% of our patients showed this characteristic during isoproterenol. Even if a much more stringent criteria for high risk, which has been suggested in some previous pediatric studies of 220 milliseconds is used, still nearly a quarter of the patients displayed this with isoproterenol. So in conclusion, pediatric patients not only have a shorter baseline accessory pathway conduction properties compared to adults, but they also display isoproterenol enhancement of the accessory pathway conduction, and this applies among all age groups, regardless of the symptoms with which the patient presents to us. This enhanced response to adrenergic tone, coupled with the highly active lifestyles that these patients engage in, may contribute to the recent findings of a higher risk of life-threatening events, which we appear to be seeing among the young, as opposed to previous natural history studies among adult patients. Therefore, we would conclude that the use of isoproterenol should indeed be included among patients undergoing electrophysiology study for asymptomatic or symptomatic Wolff-Parkinson-White syndrome, and that's regardless of the presenting symptoms. We find that its significant arrhythmias and significant enhancement of conduction in these young active patients is certainly seen with this maneuver. The decision to ablate remains an individualized decision based upon multiple clinical and social factors, but we believe isoproterenol helps us make the appropriate decision in these patients.